outcomes, including teen pregnancy and STDs. Some ways to reduce these negative outcomes include developing programs for teens as well as the parents. And we ask why develop programs for the parents. When parents talk with their children about sex, teens are more likely to wait before having sex as well as use condoms of birth control, and they're less likely to get pregnant or get an STD. We know a lot about some things that might affect the parent-teen communication about sex, including the parents' attitudes, barriers to parent-teen conversations, and what parents might think might happen if they talk to their teen about sex. And we do not know much about the parents' perceived social norms, which are what parents believe other parents do and think about talking to their teens about sex. So we ask again, why are perceived social norms important? What you think other people do influences your own behavior, and parents who think other parents talk to their teens about sex may be more likely to talk to their own teens. I work with Dr. Ager's research group, and they dealt with the teen sexual behaviors, and Dr. Akers develops programs to help parents talk with their teens about sex. The survey project that I worked with developed survey questions to measure the aspects of parental communication, including the attitudes and skills for communicating with teens about sex. It was a two-step process, and the initial survey was completed in 2009, and I am working on the confirmatory survey, which is in progress right now. I helped to recruit mothers to take the survey, as well as I entered and analyzed the data from the survey. I asked if the mother's level of education was related to the perceived social norms regarding communicating with teens about sex. The method that I used was a survey study design. It was voluntary, anonymous, and self-administered. It was approved by the University of Pittsburgh's Institutional Review Board. Mothers or female legal guardians of adolescents aged 11 to 18 years were eligible, and it took place in an outpatient clinic at the Magee Women's Hospital. The questionnaires consisted of the socio-demographic information, and as well as they asked the participants aspects of communication. The socio-demographic information asked specifically their age, ethnicity, education, gender, number of children, marital status, and job status. And the questions pertain to parental attitudes, outcome expectations, perceived social norms, environmental barriers and facilitators, as well as skills. And I specifically looked at the education and perceived social norms. My dependent variable was the perceived social norms, and the items included what other people talk to their children about sex, other parents are uncomfortable, other parents feel it is their responsibility, and other parents think it is important to talk with their children about sex. And the participants could respond on a 4-point Likert scale, ranging from strongly agree to strongly disagree. My independent variable was education, and they could answer with some high school degree, some college, and their college degree. We analyzed this data using the chi-square analysis, looking at the correlation between the perceived social norms and education level, and we thought that the data would be significant if the p-value was under 5%. 38.3 years was the mean age for the participants. Roughly half of the participants were Caucasian, and the other half were African American. About a third completed their high school degree, or they went to high school, and the other 2/3 went to college or completed their college degree. Almost half were never married, and more than half were employed full or part-time. The average number of children for the participants was 3.04. And this slide shows the proportion of mothers that strongly agreed or agreed to each of the questions below. And as you can see, most of the mothers did agree to the statements. And as you can see on this slide, the mothers with more education were more likely to agree with the statements than the mothers with the less education. And you can see this if you compare the numbers in red to the numbers in black. And the last column shows the p-value of each question. And since it is under 5%, the data is valuable, I guess. In conclusion, education matters, and mothers with higher education are more likely to believe their peers or talking with their teens about sex. The limitations to this data came from the selection bias. Mothers who participated may be more likely to hold these opinions compared to mothers who do not participate. And the social desirability bias, which states that mothers may have picked answers that sounded best even if their answer did not reflect their true feelings. And lastly, the results may have not been generalizable because our results came only from one hospital, and our clinic population was mainly low income and uninsured, so it could have differed from other populations. The two main lessons I learned from this research internship was about parental communication and research methods, the different kinds. I learned that some mothers may be more interested or willing than others, and mothers of all education levels should be included in sexual health programs regarding communicating with adolescents, and slicing and dicing data leads to skewed results. These are my references, and I would also like to thank Dr. Akers and Dr. Chang because they helped me a lot with this program. And Cindy was kind of, I worked with her most of the time, and she helped me through everything. And also Janet Hawaliak for making this whole project possible. And Miss Gloria, I worked with her in the clinic, and all the mothers who participated in